Hypothyroidism. In this presentation, we will discuss the hormones that the thyroid secretes, how and why they are secreted, and what could go wrong to cause hypothyroidism. The body's balance and regulation greatly depends on the HPT axis, which include the hypothalamus, pituitary gland, and thyroid gland. When the hypothalamus needs more hormones from the thyroid gland, it secretes thyrotropin-releasing hormone, which the pituitary gland responds to by secreting thyroid-stimulating hormone, which then stimulates the thyroid to produce T3 and T4. Step 1. In the hypothalamus, there is a group of neurons that can secrete hormones onto the anterior pituitary gland. This group of neurons is called the paraventricular nucleus, or PVN. PVN secretes thyrotropin-releasing hormone, or TRH, and it travels through the hypophyseal portal system, which are blood vessels, until it reaches the anterior pituitary gland, then stimulates it. In step 2, TRH stimulates thyrotropes, which are cells in the anterior pituitary gland. The thyrotropes then release thyroid-stimulating hormone, or THS. In the upper left-hand corner, we have a visual of the thyroid gland and where it is located in the body. If we look at the picture below it, we can see a zoomed-in version of the thyroid gland. Here we can see thyroid follicles, the follicle lumen, which contains colloid, and the tiny follicular cells. Looking at the final picture on the left, this is an actual piece of thyroid tissue under a microscope. The tissue is dyed so we can see everything better. Look at the tiny follicular cells. It is within these tiny cells that the thyroid hormone production takes place. In the upper left-hand corner, you can see a zoomed out picture of where we are in the thyroid tissue. There is a capillary to the left that has sodium and iodide inside. You can see by the circled number 1, the TSH hormone coming into the follicular cell through the TSH receptor. TSH will stimulate the thyroid follicular cell to synthesize thyroid hormone. After TSH binds to the follicular cell, a protein called thyroglobulin will be produced through the endoplasmic reticulum. Golgi apparatus pack it into vesicles, and thyroglobulin enters the follicular lumen through exocytosis. Take a look at the sequence from the TSH to where TG is in the yellow portion of the picture. Notice TG, or thyroglobulin's structure in this part. Let's go back to the capillary on the left. Sodium and iodide importers are attracted by protein kinase A phosphorylation, and therefore bring sodium and iodide to the surface of the capillary so they diffuse and enter the cell. They are then transported to the lumen of the cell by pendrin. Protein kinase A then activates the enzyme thyroid peroxidase, or TPO. TPO uses hydrogen peroxide to oxidize iodide and make it iodine. TPO places iodine onto tyrosine, called organification or iodination of thyroglobulin. One iodine is placed on tyrosine, making monoiodotyrosine. 2 iodine are placed on tyrosine, making diiodotyrosine. TPO combines MIT and DIT molecules to make triiodothyronine and tetraiodothyronine. So 1 MIT and 1 DIT equals T3, which is triiodothyronine. And 2 DITs make T4, which is tetraiodothyronine. T3 and T4 are both the thyroid hormones. Notice the difference of thyroglobulin from the beginning to the end. You can see him getting built up. Make note of the T3 and T4 structures. Notice anything? We'll circle back to that. Thyroid hormones remain bound to thyroglobulin for storage in the follicular lumen. If the body is ready for them to be released, the thyrocyte will grab up the iodinated thyroglobulin by pinocytosis, which is the cell drinking it up. Then, proteolysis happens when a lysosome comes and cleaves thyroglobulin from T3 and T4, collectively called the thyroid hormone. Thyroid hormone then enter the bloodstream to act on target tissues. Most are bound to thyroxine binding globulin. About 20% of the thyroid hormone released from the thyroid is T3 and 80% is from T4. T3 is considered the active form. Most of T4 is converted into T3. Here we have the chemical structure of thyroid hormones. Tetraiodothyronine, which is known as T4, and triiodothyronine, known as T3. As you can see, the capital letter I in purple represents one iodine molecule. T3 has 3 of them, and T4 has 4. Here are all the reasons we need optimal levels of T3 and T4. Brain development, body weight, body temperature, bone health and muscle contractions, menstrual cycle, metabolism of glucose, breathing, heart rate, and much more. So what if your thyroid can't produce enough hormones? Why wouldn't it be able to? We know the many parts of the body that the thyroid hormones affect. What could happen to the body in deficiency? Whoa! The second photo is how going untreated and undiagnosed for about 2 years can show up physically. Types of hypothyroidism include primary, where a high TSH level indicates that the thyroid gland is not making enough thyroid hormone. Secondary, where a low TH may result from abnormality in the pituitary gland, which prevents it from making enough TSH to stimulate the thyroid. Tertiary, which includes hypothalamic disorders, and Hashimoto, which is an autoimmune mediated destruction of the thyroid gland. Symptoms include bradycardia, fatigue, cold intolerance, weight gain, poor appetite, hair loss, dry skin, constipation, myopathy, cramps, entrapment syndromes, depression, impaired concentration, and memory. Some non-genetic causes would be thyroid surgery, radiation therapy, thyroiditis, and pregnancy. Levothyroxine is the most prevalent and sometimes only treatment for hypothyroidism. Notice the chemical structure. There are 4 iodine molecules. This medicine is synthetic only for T4. It is important that levothyroxine is used more appropriately to achieve maximum benefit for patients. In order to ensure this, further research should include more accurate assessments of the true prevalence of hypothyroidism in the community, optimism of the levothyroxine substitution dose, proper duration of treatment, and identification of patients who may benefit from combination therapy with levothyroxine plus levotriiodithyronine. Although my lab results show all of my thyroid-related tests are within normal range, I still feel I have trouble with some of the common symptoms, as do nearly 1/3 of patients with treated hypothyroidism. My vitamin, mineral, and fatty acid levels may be unrelated, but this is to show that hypothyroidism symptoms that are shown in my day-to-day life have my boyfriend asking me to check out other areas of regularity in my body. You can see the thyroglobulin protein in this picture of thyroid hormone synthesis. What if there is a structural mutation in my thyroglobulin protein, which severely impairs generation of T3 and T4? During DNA replication, the DNA separates into mRNA to be assembled into a new DNA segment, with DNA polymerase as the organizer. The end of the mRNA chain is a long string of A's called poly-A tail that signals the end of the code. What Nicole Davis says in her article is that the tails can shorten with age, which reminds me of Giovato, Magri, and Carle's statement where they said the prevalence of hypothyroidism increases with age. This could answer the reason for the spontaneous acquirement of hypothyroidism as one ages, because with age, the poly-A tail shortens. Well, so what the poly-A tail shortens? What does that mean? How does that possibly lead to primary hypothyroidism? Recall thyroid hormone synthesis. With the thyroid stimulating hormone from the pituitary gland reaches the thyroid stimulating bonding site of the thyroid gland's follicular cell, thyroglobulin production is stimulated inside the follicular cell. The thyroglobulin glycoprotein's DNA must be replicated in order for more thyroglobulin to be produced. It is thyroglobulin's physical structure that the thyroid hormones require to be produced. So that brings us back to, what if your thyroid can't produce enough hormones? Why wouldn't it be able to? The efficiency of hormone synthesis of thyroglobulin depends on the structural factors intrinsic to the protein matrix that favors the coupling reaction. It may be assumed that genetic mutations that would result in a structurally defective protein would severely impair the functional ability of thyroglobulin to serve as a matrix for the generation of T3 and T4. The depth beyond the surface explanations intrigue me. If 1/3 of medicated hypothyroid patients still experience symptoms, is there something else we could do besides band-aid the issue? Is there not a way to fix the issue at the root? Could we prevent or repair thyroglobulin gene mutation?